Good evening, everyone. I'm Tony Segreto, and once again, so very honored to be your moderator for tonight's In the Know Town Hall. We welcome you to our continuing series, The Science of Aging, and tonight we will continue to highlight an incredibly important topic. We're talking about our heart health. In fact, it's been our focus the entire month as February is deemed American Heart Month. Now, maybe some of you were actually with us last week. We had an incredible session on the most innovative research and treatments that are available at UHealth to treat heart disease. Well, tonight, we're going to look at prevention and the steps we can all take to improve our heart health as a way of preventing cardiovascular disease. And you know, being proactive is vitally important, especially when you see the latest numbers by the CDC that says one person dies every 36 seconds from cardiovascular disease, making it the leading cause of death in the United States. Thankfully, we have an incredible team of physicians and researchers at UHealth who are continually finding new ways to promote heart health. And tonight, they're going to help us explore the newest innovations in heart disease prevention. They include Dr. Jeffrey Goldberger, chief of the cardiovascular division and an expert in cardiac electrophysiology. Dr. Carl E. Oranger, who specializes in prevention solutions for patients who have a high risk for major vascular disease complications. And Dr. Maria Delgado, who will share her expertise in awareness, treatment, and control of hypertension. As you can see, it is truly a world-class group of experts, and we are so honored to have them with us tonight. Now, before we get started, let's go over how you can participate in tonight's conversation. After Dr. Goldberger has delivered his opening remarks, all the panelists will answer the questions that you've submitted over the last few days. But you'll also have the opportunity to submit questions during this hour-long program. It's easy. For those of you who've been with us before, you know the drill. For those of you who are new, at the bottom of your screen, you see a little Q&A feature. Right there, you will send us your questions. And we want to remind everyone that all the questions sent in are anonymous, and we promise, I promise you that we're going to get to as many of them as we possibly can. Because of that, and I know we're going to be just inundated with questions just the last couple of days, those you submitted, it's time to get going. We're not going to waste any time. It is my pleasure for some opening comments to introduce Dr. Jeffrey Goldberger. And Dr. Goldberger, again, such an honor to have you. We loved having you last week, and we can't wait for tonight.
Good evening, and thank you. I want to be here with you all on behalf of our Division of Cardiology. They are really an amazing group of healthcare professionals who are committed to saving lives and finding the newest innovations in heart health. Even though February is Heart Awareness Month, maintaining and strengthening our heart health is something we really need to be focused on year-round. This is something we address quite a bit in my practice as a cardiac electrophysiologist because we see patients with heart rhythm disorders, and this plays an important part in our care of these patients. The most common conditions, such as arrhythmia and atrial fibrillation, can actually be prevented by treating these factors, such as poor diet and lack of exercise, which leads to obesity, diabetes, and a host of other issues that participate in the development of these arrhythmias. So keeping these factors in check are really good, really important for heart health. Tonight, we will share with you the best ways to do that. My esteemed colleagues on tonight's panels have made incredible advances in addressing the impact that high cholesterol, high blood pressure, diabetes, and genetics can have on your health. It is great information that you need to factor into your lifestyle every single day, not just during Heart Month. We hope to discuss all of this tonight and look forward to answering your questions. Back to you, Tony.
Dr. Goldberger, thank you so much, and thank you for setting us up for our Q&A feature. We're going to start right off the bat. Dr. Oranger, you're first up. Great to have you with us, Doctor. What is the best way to determine if you're at risk for a heart attack or stroke?
Let's get here. Now you can hear me. One of the most important things to remember is that in this era of COVID, it becomes extremely important for us to remember that people who succumb to COVID are those who tend to have lots of cardiovascular risk factors. They tend to be obese, they tend to have diabetes, high blood pressure, established cardiovascular disease. And so this has really brought to the fore the importance of prevention. We want to do everything we can to keep people out of trouble from cardiovascular disease. So Tony's question was, what is the best way to determine if you're at risk for heart attack or stroke? And the first and foremost thing that you need to do is to choose your doctor carefully. Many people will get a doctor who is a friend of their families or takes care of a friend of theirs, but it's important that you also have a physician who is knowledgeable, who teaches, who contributes to education and research. And these are some of the assets that we have at the University of Miami. But when you see a physician and you're asking the question, am I at risk for heart attack or stroke? One of the approaches that we recommend is the use of a risk calculator that was developed by our guidelines writing group. And we enter a number of these factors into this calculator, things like what is the patient's age, what is the patient's sex, what is their blood pressure, what are their total cholesterol and HDL cholesterol levels, are they smokers? We put these factors into the risk calculator and come up with what is called a 10-year risk for heart attack and stroke. And we often use that to begin the conversation with our patients about whether preventive strategies are warranted, whether just good diet and exercise, or whether the addition of medicine should be considered. Sometimes we look at other clinical factors. What is your family history? Do you have other concomitant medical conditions that might increase your risk? And then when the decision remains uncertain, we oftentimes today are moving to use what's called coronary calcium scoring, which represents a easily done 10-minute non-contrast chest CT that's done without an IV. You're in and out. It immediately looks for any hardening of the walls of the artery supplying your heart. And this is important because we know that the more calcium that is seen in the artery walls, the more plaques of cholesterol are in those walls and the greater a person's risk is over time. So this helps us to personalize risk to a particular patient. And once we hone in on risk, then we're in a better position to determine what treatments make the most sense for a given patient.
Dr. Orringer, thank you so much. Dr. Goldberger, how do I know when it is just stress and not something more like an arrhythmia?
Thank you, Tony. That's a great question. So stress and arrhythmia are really linked very, very closely. Everybody has stress. Not everybody has an arrhythmia, but stress basically causes an adrenaline-like release in your blood. So it's your fight or flight reaction. And the adrenaline that gets released, and often that's very important. For example, when you exercise, you have to get your adrenaline going to be able to increase your heart rate. But it turns out that that same adrenaline can aggravate or be a trigger for heart rhythm problems. So many times, people will ask me, if they have an arrhythmia. They said, if I got rid of my stress, can I get rid of my arrhythmia? I say, well, it's possible, but most people can't get rid of stress. It's just not, it's not possible to get rid of that 100%. So again, everybody has stress. It does promote or trigger arrhythmias in many people who are susceptible. So it's important to realize that they both can coexist.
Dr. Goldberger, thank you very much. Dr. Delgado, it's so nice to have you with us. Welcome. Tonight, we have, it's a kind of a two-part question here. What is hypertension? What are the risks of hypertension? If I can throw something in, is there a difference between hypertension and blood pressure, high blood pressure?
Okay. So good evening, everybody. I like to think when you look at your first slide, it says aging, right? So hypertension is that disease that gets old with us. And the one thing, if I wanted something to come across tonight, is that hypertension is not a number. Hypertension is a systemic disease that starts pretty early in life, even though we don't see blood pressure numbers. With endothelial dysfunction, meaning that the lining of your arteries are not working that they should be, and it progresses in time. And when you look at the fact that that half of the United States adult population is hypertensive. These have to make us think. That means that in this room, half of us are either hypertensive or will become hypertensive. So it's a very, I call it a social disease because it runs in family in 98% of the population with hypertension. It progresses over time, and it's this big umbrella that embraces cardiac risk. So we have a disease that starts early in life, embarks 50% of the adult population, and is the #1 risk for cardiac disease. So your question, Tony, is true. Number is not synonymous of hypertension. A quick example, you have a kid, 20 years old, with 120/70. And you have another one, 120/70. Both kids, one have parental or grandparent history of hypertension. The other one, there's no parental or grandparent history of hypertension. Even though both kids have normal blood pressure, the kid with parental hypertension already have a higher risk, not only of developing hypertension, but also having in the future cardiovascular complications or events. So it's an extraordinary public health problem, not only in the United States, but worldwide.
Fascinating. We're going to keep you here, Dr. Delgado, because we just had this sent to us. Is kidney health related to heart health?
Yes. So there is a relationship between kidney and blood pressure. And if you think about how the kidney regulates water and salt, for example, and you imagine that all that fluid is reabsorbed through the kidney, when you have a good kidney function, most likely your blood pressure is well controlled. However, most of the hypertensive subjects, right? They're young. You can have subjects at 18, 20, 30, 40. Not necessarily they will have kidney problems. The longitudinal effects of hypertension over the vessels is what cause, at the end, kidney problems. So it's like, it starts with I can affect with hypertension the kidney, but at the same time, once the kidney is sick, it will affect hypertension. So it's extraordinary, the relationship of kidney and vascular health.
Thank you, Dr. Delgado. Dr. Oranger, we have a multi-level question for you. How do I know whether I really need to take a medication or whether I can reduce my heart risk enough with a good diet, exercise, and supplements? What are the ideal foods that can help that?
Well, it's a great question, Tony, and I want to start out by saying the first step, again, is to use that risk calculator to give us a basic idea, at least population-wise, of what our risk is. To get more personalized information, physicians often order a coronary calcium score, which then gives us specific information, almost like a roadmap to prevention, that helps us to know which patients are likely to do well with just lifestyle change and which patients require both lifestyle change and medication. We find that those who are in the low risk category, that is less than 5% risk over the next 10 years, oftentimes do very well with lifestyle measures, dietary interventions, regular aerobic exercise. Those who have no coronary calcium, that is coronary calcium scores of 0 on a coronary calcium score test, and who are not smokers or diabetics or have a family history of early heart disease, those individuals also tend to do very well with lifestyle intervention. When we talk about lifestyle, we're talking about, first of all, being culturally sensitive when we give dietary recommendations. People who are Black or people who are of Latino, Hispanic ethnicity oftentimes require different types of counseling to provide sensible dietary eating. But in general, diets that are low in saturated fat, high in fresh vegetables and fruit, whole grains, legumes, low-fat dairy, and avoiding fatty meats, processed meats like bacon and processed luncheon meats, staying away from sugary beverages, staying away from fast food, frequent sugary desserts. You're taking away all my fun, Doc, but the truth is that those are so many of the things that contribute to unhealthy cardiovascular patterns that result in disease over time. With regard to alcohol, we generally suggest 2 servings of alcohol daily in men as the upper limit and 1 in women. And also portion control and more fiber in the diet tend to lead to healthier, greater heart health. When it comes to exercise, we usually talk about combining aerobic exercise, about 150 minutes per week for health maintenance, 200 minutes or more a week for weight loss, and also adding some strength training and flexibility to maintain general health. And finally, the question about supplements is easy. None has benefit as compared to those of prescription medicines where we actually know the benefits versus risks. The supplements, and Americans have very, very expensive urine, but for most cases, most of the supplements don't provide any significant benefit that has thus far been determined.
Thank you, doctor. We're going to keep you here though, because we just had this sent in. What is the evidence in the medical literature that people taking a statin benefit from supplementing their diet with CoQ10?
Well, this has been one of the really interesting areas. I'm one of the authors of the 2018 American Heart Association, American College of Cardiology cholesterol guidelines. So these are the cholesterol guidelines that are used nationally. And in this guideline, we felt that the evidence at that time on CoQ10 indicated that there was no evidence to suggest that CoQ10 was beneficial. Now, having said that, I have occasional patients who will swear up and down that when they're taking a statin and they take coenzyme Q10, they feel that any muscle symptoms that they may have noted seem to be better controlled. So I see that there's no harm in coenzyme Q10, but so far the studies have not shown significant benefit of this in terms of mitigating any side effects that people think are related to their statins.
Maybe the placebo effect, right?
Well, whatever it is, if they feel better and I see no harm, it's okay. We just don't prescribe it in general for patients on statins.
Dr. Oringer, thank you. Dr. Goldberger, how is stress related to heart disease?
Okay, so I see we have a lot of interest in stress this evening. Let me be clear, stress is really sort of a double-edged sword. Our bodies are designed by necessity to be able to deal with stress and to be able to handle situations, as I mentioned before, that fight or flight response. I think one of the best examples of that, of the double-edged nature of this, is what I call the paradox of exercise and sudden cardiac death. Sudden cardiac death is one of my particular research interests, and this is basically somebody who's been perfectly healthy. They may have heart disease, but they've been doing fine. You talk to them one day, and the next day you hear they just dropped dead suddenly. That's usually due to an arrhythmia, to a rapid heart rhythm that causes collapse, and if the patient's not resuscitated, they die. Now, it turns out that there's a nice study called the Physician's Health Study where they looked at the risk of dying related to exercise. And what they found is if in a population of physicians who don't exercise regularly, the risk of dying of having this sudden cardiac death during exercise was 70-fold. So it sounds like maybe you shouldn't exercise. But that's a very bad conclusion, because it turns out that people who habitually exercise have only about a 5-fold increase of having sudden cardiac death during exercise. So that's the paradox. You protect yourself by habitual exercise, but that doesn't mean that there's not an acute risk with each episode of exercise, but it's just much smaller if you habitually exercise. So that's the same issue with stress. I mean, it's certainly a component. It can help precipitate these kinds of arrhythmias. It could have long-term effects on the heart as well, and on heart function. There's entities, it's called a stress cardiomyopathy. It can even cause an acute change in the heart function. So again, stress is something that we all live with. It's a double-edged sword. Obviously, the best thing is to be able to manage your own stress, but to understand how it does integrate with heart disease.
These stress questions seem to follow you, Dr. Goldberger. Dr. Delgado, you sort of touched on this in your first answer. Is there an age group that is more vulnerable to hypertension, and what factors play into hypertension as you age?
Okay, so again, it starts early in life, and genetics is something very important in terms of let's start with a number, because people tend to associate hypertension with a number. Well, we have a guideline, it's 130/80. Okay, I'm hypertensive, I'm not. So the number is actually a phenotype, a guide to detect patients that have bad vascular function. So saying this, if you have, just so you can understand aging, let's say mom and dad are already 60 years old or 50 and they are hypertensive, okay? And they give birth to a child. This kid at 18, 19, or 20 can become hypertensive. So there's there's this question of how can my kid, or how the child who has never smoked, never drank, only do exercise and go to high school, can be hypertensive at 18 when his parents start being hypertensive in the 50s or 60s. This is actually the genetics. So mom and dad have built in their genes risk for developing hypertension. When they get together, the kid has a greater expression. The rule of thumb is one grandparent will virtually guarantee a 50% of hypertension in the next generations. Whether or not they're mixed with risk or not, when they get married, say something. When one parent is hypertensive, is about 75% of the offsprings. And when both parents are hypertensive, is not only is almost all the offsprings, but the way it shows up is pretty early in life. And I need to make this a point, because sadly, in our community, when a kid has a blood pressure of 130/40, they get a pat on their shoulder, say, you're nervous, this is emotional hypertension that, by the way, doesn't exist. And it goes along with what Dr. Goldberger was saying regarding stress. Emotions do not cause hypertension. It just stimulates the vascular response, which in this case is abnormal. So we have kids as young as 18 and even younger than that will have being hypertensive. But like I say, remember, it's longitudinal, right? So you build up the vascular damage over time. So that's when you're going to start seeing hypertensive in their 30s, hypertensive in their 40s, hypertensive in their 50s. The other factors other than genetics that makes the expression of hypertension earlier than or later is what you do. And that's where Dr. Oringer have completely a great point. That when you prevent cardiovascular disease, you also prevent a normal response of the vascular tree that leads to hypertension. So again, those two girls or two men, both are 45 years old. One smokes, one drinks, one doesn't do exercise, doesn't diet. Both have the same genetic risk for hypertension, but the one at 40 will become hypertensive in terms of damage and target organ damage first than the other guy who is doing everything that he can to keep himself healthy. So he probably will become hypertensive when he's in his 60s. So there's multiple factors, but what I call the environmental factor is what is around you in terms of things that you see, that you have, and what is inside you. And again, stress is one of the most important things. So aging is important. Why? Because despite all the factors that we're discussing, when we get old, in our body, everything doesn't work the same. So your body is not the same as when you were 20, when you're 40, when you're 60, when you're 40. So basically, the vessels are not working the same way. The lining of the vessels doesn't work in the same way that they were working when you were young. So aging, particularly aging, is a factor for, like a trigger for this abnormal response. Anything that we do as persons, as families and communities that improve or prevent vascular damage, including with aging, will prevent what we call number, which is basically a cutoff point that something is going on that could lead to target organ damage. That for us, target organ damage is all these consequences of having long-term hypertension that attacks your heart. You get heart failure, you get vascular disease in your brain, so you develop cognitive disorders and dementia. In men, and I have to mention, because sometimes men doesn't worry about hypertension per se until there's a problem with erectile function. And sometimes the younger, in the 30s and 40s, will realize they have a problem with blood pressure when they notice that they have malfunction in terms of their sexuality. So in women, the same thing. They worry about getting old, about the wrinkles. Blood pressure or hypertension as a vascular disorder that goes from head to toe is a factor that will imply in health, in the health of the body in general, and the skin. So there is something that everybody knows right now. Hypertension is silent, but it's not invisible.
Got
So our role as a group at the university is to understand that, to make the patient understand that we not only we can detect hypertension early in life, but also we can prevent damage to all the organs.
Thank you, Dr. Delgado. That is fascinating. Dr. Oranger, which treatments provide the best protection against heart attack or stroke?
I think we always should start with lifestyle first. So it's always a heart healthy dietary pattern and regular aerobic exercise. When that is not enough, or when our risk seems to be high based upon either our calculated risk or the coronary calcium score, the most commonly used treatments are statins, aspirin, and blood pressure treatment. Statins have a very long track record of safety and effectiveness. We know that they prevent heart disease in proportion to the dose of the medicine that's used, to the intensity of the statin. The higher doses and intensities of statins provide the greatest benefit, although even lower intensity statins provide some benefit. But the more statin you're on, the more you're prevented against problems, especially if you're at higher risk. And then I know that many people worry about the potential side effects of statins. About 10% of patients taking them have been shown in certain studies to experience various types of symptoms, some of which are actually attributable to the statin, and some of which are because the patient expects to have these symptoms. And it's difficult to tell in many cases which of those a patient has, but that's why a real good history, talking to the patient carefully and trying to determine what it is they're experiencing, is a key to maximizing the beneficial effects of prevention.
Dr. Oranger, we're going to keep you here. We just had this sent to us. What do you think about doing a Lifeline screening test?
Well, the Lifeline screening test entails a number of parameters. They look at your cholesterol, they look at the carotid health, so to speak. They do various screening parameters that sent out to people, kind of casting a wide net. Interestingly, there has just been a large study which showed, and actually the United States Public Safety Task Force also suggested that there's no benefit to doing carotid screening in asymptomatic individuals. So, I guess the way I think about it is, it's kind of a way of getting people to think about their heart health, but it's not a particularly effective way to help people to know what direction to go in.
Great. Thank you, Dr. Oranger. Dr. Goldberger, What is new in the area of stroke prevention in patients with atrial fibrillation?
Okay, thank you, Tony, for a non-stress question. So atrial fibrillation is the most common arrhythmia that we deal with, and really one of the most devastating consequences of atrial fibrillation is stroke. The kinds of strokes that you get with atrial fibrillation are really the most devastating kind. And over the years, we've learned that if we place patients on blood thinners, that we can dramatically lower the risk of stroke. So there are a couple of new concepts and new items that have really emerged over the last couple of years. First is the fact that people who take blood thinners have about a 3% risk of major bleeding per year. So that's not a lot, but still 3% is quite significant. And if you're one of those patients who has that kind of significant bleeding risk, you can't take the blood thinners. In that case, we do have another option now. There's a part of the atrium, and that's the chamber that of the heart, the top chamber that's responsible for the fibrillation and where the blood clots form that lead to the stroke. So there's a part of that left atrium called the left atrial appendage where 90% of the blood clots form. And now we have a procedure that can be done without surgery to basically close off that left atrial appendage. It's called the Watchman procedure, Watchman device. But we also have surgical approaches that can actually be done with very low risk to actually close that left atrial appendage. So there are now options for people who can't take blood thinners. The other thing that we're working on is on the other side of the spectrum. So it turns out that 90% of people who have atrial fibrillation have about a 5% annual risk of stroke. So again, that doesn't sound like a lot, but it's certainly substantial if you're one of those people who has a stroke. And taking blood thinners reduces that risk to under 1% per year. But what about the 95% of people who don't have that risk of stroke, who aren't having a stroke per year? So we're now talking about treating at least over 5 years, 50% of people with blood thinners that have a major risk of bleeding with, who may not ever need it because they're not at risk of having a stroke. Right now, the way we assess that risk is with clinical risk factors that were developed in large populations, but it's not really specifically looking at the blood flow inside the heart to try to understand if a particular individual has poor blood flow that predisposes them to the blood clots that lead to the stroke. So we're now developing a new technique using cardiac MRI to be able to actually look at the blood flow inside the heart. So that's one thing that we're doing. And I'm also proud to announce we just got a large grant from the NIH to look at a variety of blood biomarkers and genetic markers from the fat tissue around the heart and metabolomic markers, so markers that come from metabolism, to try to assess the risk of atrial fibrillation, which of course is the primary driver for this stroke.
Dr. Goldberger, thank you. It's just fascinating information. Dr. Delgado, you get the big question of the night that is asked, I'm sure, to every day. Is it true that red wine is good for our heart, and what does the research actually show?
The research actually comes, there's several studies, especially gathering data from Europe, that's where the typical diet involved rich in certain fats, vegetable, fruits, and also wine. And it had been shown that it's what they call the French paradox, that these patients or this population that drink wine and a little bit of more fat actually have less risk of heart disease. One of the components of the wine, which are the phenylphenol, are laderoresterol, which everybody hears about and taken in form of a supplement, is been shown to have antioxidant and anti-inflammatory effect on the vasculature. But to this day, there is actually not a clear-cut association between the effects of wine and vascular disease. Actually, the American Heart recommendation is that if you don't drink, don't drink. And if you do drink, just drink small amount, like 1 to 2 cups of wine in a man and 1 daily and 1 cup in the woman. But there is not, there is association, for example, with increase in HDL, also decrease in the prevalence of diabetes. However, wine it can be tricky, not only wine specifically, it can be tricky because wine in a person who already have fatty liver, who already have a very bad diet, the damage to the liver will be worse. An alcoholic or somebody who drinks a bottle of wine every single day, we can even develop the risk of having direct damage of the myocardium secondary to wine. So like Dr. Oringer was saying, it's something good in terms of very mild or moderate intake, but it's not a recommendation, meaning that we do not recommend a person who doesn't drink to drink wine. You see what I'm trying to say? So
I see. I get it. I get it. It's kind of a sticky wicket there. I get it.
Yes.
But we're gonna follow up with you, Dr. Delgado. This was just sent in. Can a patient have an LAD CTO widowmaker without any classical symptoms?
Yes. And I don't know if the person who's asking is actually a female or a woman, because you can have, a woman typically will have cardiovascular symptoms or coronary symptoms that are completely atypical. And the typical symptom of having the shoulder pain, the jaw pain, the chest pain, sometimes doesn't happen, okay? And if you're in top of that diabetic, your perception of pain can be also impaired. So what happened with the coronary artery is that even though you have what you call the widowmaker, you also have significant collaterals. So the patient will not have symptoms on exertion in most of the time. But the one thing that I want to address is, in terms of women, is not only the bias that women have on their own health. So if you have a pain on your abdomen or somewhere and you have already risk, you kind of tend to say, okay, that's nothing, I don't care. I have to take care of the kids' work or everything else. So women already bias themselves in terms of their perception of what's going on in their body in the cardiovascular scenario. And sadly, and what is happening in many community hospitals is that if you put one woman and one man side by side, the 40-year-old with whatever pain, even though he was drunk at the time of he came to the ER, he will get a workup for coronary heart disease. The woman most likely will be told, you probably have gastritis. So yes, you can have a significant coronary artery disease with not the typical symptoms. And this is where prevention comes in. So you talk to your doctor, maybe there's no chest pain, but there's something. Let me just take 1 minute to give you an example, a very extraordinary example. This is a 60-year-old who comes to the clinic for the first time for hypertension assessment. That's all. I have high blood pressure, never been treated before. Okay, and we talk. And in that assessment, I ask her, well, do you get tired when you walk? Oh, yeah. But tired like you're short of breath or what? No, I get short of breath significantly. And she's also diabetic. She also had dyslipidemia, and she's morbidly obese. The lady had a systolic blood pressure at the time of the visit, around 160, and this is what she normally have at home. I remember that same day I told her, listen, you're having symptoms. You're telling me that you have to stop because you're short of breath. Sometimes you get some sort of like a little weight, but you're not sure what it is. You thought it was your stomach. I want you to get a stress test. This lady, we coordinated almost immediately in the next couple of days to get a stress test. The stress test was positive. Our team was able to do a cath because the stress test was positive. That's one of the things you do. The lady went from cath to a CABG. So this lady had triple vaso disease and she underwent open heart surgery. What I'm trying to tell you is that she didn't come with any symptoms, quote unquote, that we know as cardiac. She was telling me she was getting tired. And sometimes she had this heaviness that she wasn't sure what it was, but since she's obese, she thought it was food. So it's important that when we treat and we assess cardiovascular disease, we have a team. And this story of this lady from first visit until she underwent her open heart surgery would not have happened if we don't integrate what all the team that we have. From the moment that she gets the stress test, from the moment that she gets the open heart, the cardiac rehab, everything comes together. And sadly, that's why I started with female. This woman goes to a regular primary doctor, okay? And I'm not discriminating, but she goes to a doctor, they'll give her a prescription, and this lady could die of sudden death in the future because she already has significant triple vaso disease with no typical symptoms of coronary artery disease.
Thank you, Delgado. That's great information. Dr. Oranger, this question just sent in as well. What is a calcium score test and how can you reduce a calcium score? Dr. Oranger.
That is precisely what we were talking about, the coronary calcium scoring test. This is a 10-minute test. It's a CT scan. It provides as much radiation to the patient as a mammogram, so it's a very low radiation exposure that immediately gives us information about deposits of calcium in the artery walls. And the reason that's important is because calcium goes where cholesterol goes, so that we can have a very rapid assessment of how much plaque the person has. The likelihood of future heart attack depends upon how much plaque is present. It doesn't depend, by the way, on the presence of a blockage. So the term that many of our surgeons like to use, or many people who have done interventions like to use, is quotes the widowmaker. In fact, we know today that it doesn't matter if you have a significant obstructive disease, if you're not having symptoms. What matters is that those kinds of situations can, in most cases, be treated medically, and a person's risk can be reduced to the extent, matter of fact, they can be reduced substantially, such that even though a person has a blockage, they can be very nicely handled over many years and not have any heart attacks. So again, we want to find out how much plaque is present so that we can be sure that our preventive treatments coordinate with the risk that a patient has.
Thank you, Doctor. Dr. Goldberger, this also just sent in. I am a big fan of the U. My cardiologist, my endocrinologist, and neurologist are all looking at the same information. Please speak to the benefits of interdisciplinary collaboration.
Thank you for that question. I just typed the answer to that so I can repeat really what I said. I think that's really one of our major strengths at the U. We bring that, every day to the care of our patients. There's constant interaction between doctors of different specialties to help coordinate care. But I think we take it even a step beyond that. Many of our programs are interdisciplinary by nature. So for example, our atrial fibrillation program brings together cardiologists, radiologists, endocrinologists, engineers to try to tackle the challenges that are inherent in atrial fibrillation. Other collaborative programs that we have are in vascular medicine, where we have people from vascular surgery, from cardiology, from hematology, from rheumatology, all working together on the issues related to this. Our multidisciplinary hypertension clinic, led by Dr. Delgado, is another example. We're also bringing together a neurocardiology working group, people who are interested in the nervous system effects on the heart. So we have a very strong focus on multidisciplinary care and also multidisciplinary innovation.
Thank you, Doctor. Dr. Oringer, I hear very often that someone is asymptomatic and then they suddenly have some form of heart disease. At what age should I begin seeing a cardiologist, or how often should I see a cardiologist, even if I don't have symptoms?
You know, in most cases, those who develop a sudden heart attack or stroke have risk factors. They have risk factors that predispose them to developing this problem, and a good preventive care evaluation can generally identify those risk factors. So preventive care usually should start with an individual's primary care physician. If there's any doubt, it's useful to see a cardiology specialist to have them look more carefully at a person's cardiovascular risk. So there's no absolute age at which a person should not consider seeing a cardiologist if they're very concerned about their cardiovascular risk.
Thank you, Doctor. Dr. Delgado, are there any new innovations to monitoring high blood pressure at home?
Yes, and I just want to also make a point. The hypertension program is actually part of a comprehensive hypertension center. And it actually pulls, like Dr. Gobler was saying, pulls the collaboration of different specialties aimed literally to the comprehensive evaluation of a hypertensive patient. So one of the things that we do when you first see a hypertensive specialist is look into 4 pillars. So one pillar is your genetics that we talk about. The other one is the biochemistry, which is a fascinating world about how hypertension differentiates from one another in terms of the kidney and the endothelium and the central nervous system integration. The other one is a physiologic one. Here's where your question comes in. The blood pressure, and I want somebody, I think this is going to make a smile more than one. I have had patients ask me, doctor, there's something wrong with my blood pressure, what it is. Well, it changes. It should be like 120/70, and why does it change? That's abnormal. And I tell them, well, it changes because you're alive. The minute you have one number, you're dead. So no, we change, and blood pressure is actually a dynamic response that you have all the time because you're alive. You need oxygen, and that's what the blood pressure does. Bring the pressure. The blood pressure is the pressure of the blood through your vessels, so you need oxygen, and that's what happened all over. So the variability of the blood pressure is very important. So one of the key things, that one of the key instruments that we do is the 24-hour blood pressure monitoring. With that, we assess 2 very important things. One, how it varies during the day. How do you respond to your work, to your eating, to your habits? And the patient can see that, can see the variation, and can also understand that that's what we do. Your blood pressure is going to vary over the daytime. It's just, we don't want you to have a spike in the 170s or in the 180s, but it's going to have a variation. At night will be, in my opinion, one of the most important assessments. So remember, you take this blood pressure cuff home, you keep it all the time, and when you sleep, you keep your blood pressure cuff as well. At night, the variability is very interesting to assess. Why? Because if you sleep, your blood pressure should go to bed as well. So there's a curve that we call deeping curve. So there are people that deep, so we call deeping patients, the curve goes down. It means that the blood pressure is going down as part of going to sleep. But there will be a group of patients that the blood pressure doesn't go down, it actually goes up, okay? Taking out that the patient woke up 10 times to go to the bathroom, not the majority, but I will say 50% of the patients, of my patients that actually have non-deeping status, meaning that the curve goes up, they have an impaired oxygenation at night. And this is what we call a sleep apnea. So in a sleep apnea, it's a state of fire in the body. Why? Because you're not providing oxygen because you kind of stop breathing for a while, and your body wants to quote unquote wake you up. It's not that the body wakes you up. It's just systemically the body is awake because you need oxygen, and that leads to reactions that will keep the body like awake. And when we talk awake, we talk about blood pressure being high. There is a stress over your pancreas as well. So your insulin gets liberated, the catecholamines get liberated, anything that makes your body be alert. So the 24-hour blood pressure is an extraordinary tool for both the physician and the patient understand what's going on and what risks are associated to the variability. Another, this is more innovative and is in plans to be installed in our program, is what we call literally a patch. So we're going to be able to put a patch on our patients here, literally in the center of your chest. That patch has the ability to do live, meaning on the patient can check it on their phone as well. Continuous monitoring of blood pressure, heart rate. You can actually see the rhythm, but it's only one lead. The oxygen, and another 12 variables of what's happening in your heart and your vasculature. This actually is an extraordinary tool. The patient will not get all that information because probably they will not understand, but they can actually look at their phone and see all the changes in the majority of the variability. And that will allow us to do early intervention. And most importantly, if the patient, something's going on with their body where either the blood pressure is too high or there's something with their heart that we can actually monitor, we can prevent this patient from coming to the hospital. See what I'm trying to say? We can do early intervention or prevent complications. So these are extraordinary tools that are coming in, but I guess, like I tell everybody, when you're hypertensive, you look back, and that will tell you who you are, mom and dad and grandparents. But if you have children, the blood pressure disease as it is doesn't start with you, correct? So you have your kids. So when we see a patient, it's like seeing the family. So I get the kids, and even though the wife are not genetically related, they also want to know what's going on. But it's really a
fascinating, doctor.
Not only, Tony, this can not only fascinating. What is the sad part of this story? Of 4 patients that know that they're hypertensive, only 1 is well controlled. So we have 75% of patients that are known to be hypertensive, that their blood pressure is not well controlled. And that implies what we call target organ damage.
Dr. Delgado, thank you. Dr. Oringer, thank you. Dr. Goldberger, amazing. We're going to get to you for final comments. That's going to be our last question of the night. This hour has just flown by. So Dr. Goldberger, as we close this town hall, can you please give us some of your final thoughts?
Sure. Thank you, Tony, for moderating this important discussion, and thank you to everyone who participated. We really appreciate the opportunity to answer your questions. We appreciate your interest in what we do and generally the support of our community. I want to recognize the work of our faculty and staff for their dedication to our patients. They are committed to being among the best in the world in what we do. The enthusiasm, commitment, and expertise of all of our physician scientists reflect the kind of drive we need to successfully develop new treatments against cardiovascular diseases. It is philanthropy that really helps to ensure that we have the best people and we provide them with the best resources and infrastructure. To that end, I want to acknowledge the generosity of the Board of Trustees, the leadership, and our loyal donors. You continue to help us set new standards of care, and it's your support that really makes this happen. You inspire us to go above and beyond to find the solutions that will make a difference in patients' lives. So thank you very much.
Dr. Goldberger, thank you again. Thank you to all the panelists for this In the Know Town Hall. Over the past, 12 months now, 11 months, we started in April, we presented numerous In the Know hours. We're showcasing our amazing doctors and researchers at UHealth. And every single time that we do, I feel more wowed and more impressed by not just their expertise, as you saw tonight, but their unyielding passion to serve not just our U family, but the community at large. And tonight was just another example of that. We should all be very thankful that we have UHealth in our community. And for those of you who are joining us tonight who are alums like I am, we have a lot to be proud of. Please remember that a full recording of this program will be posted online. Look for the link in the coming days. Now, in a moment, you're going to see a survey about tonight's town hall on your screen. Please just take a minute, and it takes less than that actually, to submit your feedback, because what it does is it helps us understand your interest and it'll help us improve our program. As always, we wish you and your family good health. Stay safe, and remember, it's all about the you. Good night, everyone.